Okay, so welcome back. Let me share the slide again. Okay, so like I said, the children are prone to bacterial infections, but they are able to take care of their viral infections, fungal infections, protozoal infections because their T-cell mediated immunity is intact. Okay. So the next thing is the common variable immunodeficiency. This is a group of congenital deficiency, which is characterized by decreased levels of gamma globulin. So you have decreased levels of immunoglobulin. Then they have a decreased antibody response to infection or a vaccine. They have increased susceptibility to infections. They are similar to the Brutins. However, in this case, it is autosomal recessive, so both sexes are affected equally. And you would find it usually occurs later in life. And because there are few, the antibody levels are few, they are not absent. So it usually occurs later, like the second or the third decade of life. And mostly when you check the blood levels, they have normal levels of the mature B cells, but the plasma cells are absent. So it means that, so in the Brutins, there's failure of progression from the pre-B cells to the B cells. Here in common variable immunodeficiency, the B cells are there, but there's failure of progression to plasma cells, and the plasma cells which give the antibody response. Okay, now there's isolated IgA deficiency. This one is very low as well, 1 in 700 individuals. And IgA, the problem is that there's a deficiency in IgA. We know that IgA is important for mucosal protection, as we mentioned yesterday. So the mucous membranes, the respiratory system, the gastrointestinal system. So if you have an isolated IgA deficiency, mostly you are asymptomatic. However, your mucous membranes would have the weakened defenses. So you have a lot of sinopulmonary infections. So frequent colds, frequent sinusitis, frequent pharyngitis, frequent pneumonias. And then also frequent diarrheas because the GIT is also affected. Then we have hyper IgM syndrome. Now, in the production of immunoglobulins, the IgM and the IgD are produced first. Then there's a switch of the IgM to production of IgA, IgE, and IgG. So if you have a hyper IgM syndrome, what happens is that switch from IgM production to IgG and IgA, IgE doesn't occur. So you have excessive or increased amounts of IgM and virtually little amount of IgG and IgA. So this means that you will have a situation where you have decreased immunoresponses at the mucosal surfaces because of the decreased IgA levels, then decreased antibody production because of the decreased IgG levels. Then you also have decreased decreased allergic reaction because of the absent IgE. The gene is X-linked, and so it means that you have more males than females being affected, and so they would present with recurrent pyogenic infections. Then the next thing is a thymic hypoplasia or DiGeorge syndrome. So DiGeorge syndrome results in a congenital defect in the thymus. Remember, we were saying that the thymus is the place or is the origin of the T cells. So if you have a problem with your thymus, then you are prone or you are vulnerable to fungal infections, viral infections and protozoal infections. And also, because the T cells help the B cells to produce antibody, you can also have some susceptibility to bacteria. So you have increased susceptibility to bacteria, but because your B cells are intact, you are able to produce antibody against the bacteria, but you would realize that you have increased susceptibility to them. And the chromosome is there's a problem on chromosome 22. There's a deletion of chromosome 22, long arm band 11. So that deletion leads to all these problems. Okay, severe combined immunodeficiency. Usually, the infants are prone to everything. So, what watch TV? Not in my room. Eh? Why aren't you watching TV downstairs? Mommy wants a tablet, so get a tablet for her. Where is it? Okay, so let's continue. So they are prone to both, they have problems with both the B cells and the T cells. So they are prone to, you can't find it. Check the bed. It's here. Oh, sorry, I didn't know. Go and play with your tablets, mommy. So they are prone to both cell defects. So they are prone to viral infection, bacterial infection, protozoal infection because of the defects in the T cells. And then they're also prone to bacterial infection because of the defects in the B cells. Okay. So the inheritance here is variable. So half of them are X-linked. The other half they have an autosomal recessive pattern. So severe combined, it's like it has a combination of everything. Both B and T cells are affected. And when it comes to the inheritance too, it is both X-linked and autosomal recessive. So that's one way to remember severe combined. So it's a combination of T and B cell, combination of X-linked and autosomal recessive pattern. So the thymus is hypoplastic. The lymph nodes and lymphoid tissues are atrophic because basically this is what the problem with the T cell production is. Then Wiskottaldrich syndrome. So Wiskottaldrich syndrome is a peculiar disease which is associated with eczema. Okay, that's what makes it stand out. All the others that I talked about, I never mentioned anything about the skin. But when you have a child who has eczema and thrombocytopenia, in addition to an increased vulnerability to infection, then you should be thinking about Wiskottaldrich syndrome. Now, Wiskottaldrich syndrome is an X-linked recessive. So here again, the boys are in trouble. And the only treatment is bone marrow transplantation, and the thymus is normal. Usually, the eczema can be so bad that you see that the infants tend to scratch the skin a lot. We saw a patient in 37 who was born, and the baby started having this very bad eczema. And usually eczema is a manifestation of an allergic reaction, severe allergic reaction in the skin. So the dietitians thought, so when the pediatrician who saw thought that, oh, maybe this eczema is just from poor excessive allergic reaction. So the mother should go and see the dietitian so that they counsel her on food that she should avoid to prevent the allergy. And you know that a lot of the proteins that we give have that potential for allergic reactions. So the dietitians advise her to cut out proteins from her diet. And so eventually you realize that this baby wasn't growing. And the thinking was that, okay, the baby wasn't growing probably because the mother's breast milk didn't have enough protein. And so that was a theory going around and around until the baby became severely ill and had to be admitted. When we admitted the patient, we were like, this baby is 4 months old, but the weight is like a birth weight like 3.5. If you were born, when we do pediatrics, you understand how the weight is supposed to increase with age, so that you know that if you go for weighing, this is how much you expect the baby to gain weight.
Okay.
But we'll do that when it comes to pediatrics. I'm just digressing a bit for you to understand the practical implications of some of these things.
Okay, it's fine.
So the baby came to our ward, was admitted to our ward, and the baby had very severe infection. A baby who had meningitis and also had a very bad sepsis or blood infection. We're like, no, and this baby is not growing. So we were like, and then the baby also has eczema. So we're like putting it all together. Maybe this baby has a deficiency in the, it's a congenital immunodeficiency. So we tested the antibody levels and then realized that the levels were very, very low. Unfortunately, this baby died.
Oh.
Yes, because the immunodeficiency had gone on for a very long time. And the baby came when the baby was severely ill and had very bad meningitis and sepsis. So we put the baby on the proper antibiotics, all right, but it was already too far gone and too late. So ideally what you do is that when you find that the baby has an immunodeficiency elsewhere in the foreign countries, in advanced countries, you put the baby on an immunoglobulin because you know that this baby doesn't have it and will never produce it. So you give the baby immunoglobulin infusions, and then you take all the. So if you are giving them formula milk, you make sure the water is boiled. You sterilize their equipment. You wash your hands. Just the main protocols to try and prevent infection all the time, because you know that they cannot fight infection. So that's a practical demonstration of Wiskottaldrich syndrome. 3 things is a triad: eczema, recurrent infection, and then thrombocytopenia. So just do a full blood count, platelets are low. This is a baby who is not growing, who keeps getting infection and has a very bad. So the last one is the genetic deficiencies of complement components. So you can have several complement components. We have C1 to C9. That's complement 1 to 9. So any of the deficiencies will give a problem. Now, we didn't really talk much about complement yesterday, but complement is something that helps, is a protein that helps to present an antigen to the immune system for destruction. So it coats the antigen, and that process is called opsonization. And typically, it is usually with bacterial infections. So if you have somebody with normal levels of B cells and T cells, and yet they have a recurrent predisposition to bacterial infections, think complements too. And complement levels can also be done in the lab, but they are just expensive. I think the last time I did complement levels, it cost 250 cedis for the whole complement to find the levels of it. So complement usually helps with protection against encapsulated organisms. So that's another peculiar thing about complement. So if you have a child who is getting a lot of encapsulated infections with a lot of with encapsulated organisms, you should think of complement deficiency. So the encapsulated organisms we know them: pneumococci, meningococci, gonococci, and Klebsiella and Salmonella. Okay, so if you have these typical infections occurring over and over again, wonder, could this be complement? All right, so we'll conclude with the secondary immunodeficiency. So like I said, usually you encounter it in disease conditions. Examples are malnutrition, infection, cancer. So the cancer itself can make you immunodeficient, and then the treatments too can make you immunodeficient. So immunotherapy, chemotherapy, radiotherapy. Patients who have had transplantation, maybe a heart transplant, liver transplant, kidney transplant, and are on immunosuppressive therapy to prevent the immune system from rejecting the transplant, are also immunodeficient. patients with renal disease, and then there's a condition called sarcoidosis. So usually these secondary immunodeficiencies can be treated when you treat the underlying cause. Some of the mechanisms by which the immunodeficiency can occur is one, loss of immunoglobulin. So if you have a kidney disease that causes loss of proteins in the urine, then the immunoglobulins are also lost, and that can be the reason for the immunodeficiency. Or there's inadequate synthesis of the immunoglobulin. So in malnutrition, for example, you don't have enough protein, so you cannot synthesize immunoglobulins. Or the medication or the severe infection causes a depletion of the lymphocytes. So that can also be an immunodeficiency condition. Now, if you consider the secondary immunodeficiencies as a group, and you consider the primary immunodeficiencies as a group, the secondary immunodeficiencies are more common than the primary immunodeficiencies. Okay, so that's my sudden end as well. I didn't have time to do the summary today. Pardon me for that. I just came from the market. I was rushing. Yes, if there are any questions, please.
Oh, Nat.
Please ask your questions. Please ask your questions.
Madam, it seems there's no question. They are all thinking about something.
You're all thinking about what?
They're thinking about the questions and it's not coming.
Madam. Hello.
Yes.
Madam, what is the underlying causes of somebody who is having
Consistent
WBC, white blood cells? Like always when they run the full blood count, their WBC are low.
WBC is an indication of, is it low, normal, or below the lower limit?
Below the normal.
Okay, so low WBC is also an indication of infection. And you know that not every infection is clinical. Some infections are subclinical. So you will not see anything, but then the levels are low.
So it means the person is suffering from an infection.
Yes, but if it keeps happening, you have to do the immunoglobulin levels to find out if the person has an immunodeficiency condition.
And madam, what kind of infection will let your WBC come low?
Any kind of infection can lower your WBC level.
So do you have to take antibiotics for infection?
No, so you have to investigate. You have to investigate and find out why by doing immunoglobulin levels.
Okay. Thank you.
Hello, madam.
Yes. Let me just chip in something. So this investigation would happen when you cannot find out why the person has an infection. So the person comes to you with a complaint and you make your diagnosis, but your diagnosis is not a diagnosis of an infectious cause. And you run your labs and you realize that there's a low WBC. However, you didn't find any infection from your examination and the history. Then you can go ahead and do it's also possible when the patient is recovering from infection, the levels may be low. So if recurrent, the patient always has low WBC, then you might want to go ahead and find out if there's any underlying cause of immunodeficiency. But it's also important to bear in mind that when the patient is recovering from infection, the levels may also be low.
This is the patient who always WBC. Whenever they are sick, the WBC is low.
No, so if they are sick, they have a problem. If they are sick, then it means there's an infection. But I had the impression that this is somebody who is normal and then you did a WBC and it was low.
No, when they are not well, like they can't really put their finger on what's wrong with them.
If you are not well, your WBC can go down when you have an infection. So there are two reactions to infection. The first one is a high WBC count, which means that your immune system is robust and is producing antibodies against the infection.
Okay.
And so there are a lot of WBCs. You can also have a severe infection that wipes out your WBCs and decreases their level. So both high WBC and low WBC is an indication of infection.
Oh, okay. Because
so if you can't find the infection, you need to do a urine culture, a blood culture, to try and look for what infection it is and where it is.
Okay.
All right.
Because we are only familiar with the high, whenever your high WBC is high,
No,
that is
the WBC can also indicate an infection.
Most doctors doesn't go ahead to investigate.
How many doctors have you known in your life?
Thank you.
The ones
You can't say most. You can say
Stubborn boy.
some,
Stubborn boy. Keep quiet.
But madam, right now you have made things clear to me because it has been happening.
You see, that's why I'm telling you that you need to understand the basics of what you are doing. Then when you see the pictures, you can put everything together. You understand? So both high and low levels can. That's why I feel that pathology is one of the most important courses to help you understand so many things.
Okay, thank you very much.
All right.
Madam, you are very good.
I'm promoting.
I'm really impressed.
Promoting my course. I hope that you read it.
No.
Yes.
Madam, when you spoke to HOD, did he allow you? Did he say you can give us our result?
Oh yes. I'll send it. I'll email it to Nick. Sorry.
Hey.
But madam,
okay,
madam.
Pressure.
Pressure. Pressure.
Before we joined the class, you were saying something concerning the I think the class assessment or something. We did not.
Yeah. I realized that you could do MCQs on Google Classroom. So I've told Nick that I'll set questions, MCQs, and then we can do them.
Pathology or both pathology and
I think both. So that we'll just
for the assessment.
Yes.
Oh, you keep on asking.
But you say you give us assignments.
I've changed my mind. I think
you see, you people keep asking this, madam will change your mind.
Telling me that the machine will mark it for me. Then when I'm
question we
the machine will mark it for me. Why not?
Question.
But Abi, you give us the areas, right?
Yes, she says.
I'll give you the areas. I'll give you the areas.
Thank you. You are the best.
People keep on repeating things. Now, madam, any idea? No.
No. Yesterday, my son was doing his assignments on Google Classroom. And then I came to look at what he was doing. I realized that he was answering some MCQs.
Oh, your son, why did you even show it to mommy? You should have.
So that's where it came to. Any other questions?
You see the way Nick is quiet. Or from one game, madam.
Hello, madam. Please,
Yes.
I want to know if you have a patient who always suffer from allergic reaction, what kind of investigation will you, lab investigation will you request?
Oh, so for recurrent allergic reactions, IgE levels will be high. And then the eosinophils will also be high. So if you do a full blood count, you look at the eosinophil count, you realize that it's higher than normal. But it doesn't only indicate allergic reaction. So this is where your history comes in, because eosinophils and basophils can be high in allergic reaction, in parasitic infection, in worm infestation. So from your history, then you can narrow down. Are you okay?
Yes, please.
Okay, there's a question about recurrent low platelets. So recurrent low platelets, it means that you have thrombocytopenia. From the immunity point of view, the only thing that's associated with thrombocytopenia is Wiskottaldrich Syndrome. But if you have a low platelet, you have to do further investigation. Is it that the platelet function is low, or the platelets numbers are low, or both? And if you have low platelet levels, there are several things that can cause. Medications can cause low levels of platelets. Some severe infections can decrease your platelet level. And malaria is also another thing that can decrease platelet level. Then you can have an autoimmune disease, idiopathic thrombocytopenic purpura, which produces antibodies which will act against the platelets and decrease their level. So when you have low platelets, it can be so many things. So you need to know what it can be and then take more history. So for example, if you know that it can be Wiskottaldrich, for example, you take history and find out, do you have eczema? Okay, do you have any recurrent rashes on your skin associated with certain foods that you eat, or allergic reactions and so on? Then when you examine to, you will see the eczema. Then it can make you suspect of that. But as for the causes, there are plenty. So history, physical examination should guide you as to which differential diagnosis to make. I hope it answers the question.
Mabel.
Brandford.
Yes.
It was Brandford who. This is a chat.
Oh, okay.
Okay.
I saw the question in the chat and I was responding.
Okay.
I hope he's clear.
Yes, please.
Oh, it's not Mabel. Let me
Oh,
type
he's
the
clear. By now, he's clear. Madam, no mind
because
that,
he's
but
not
that's how he
responding.
answers.
So let me just type the answer.
So,
Oh,
madam,
He's in a trotro, so he can't respond. He's in a trotro in a noisy area, so he can't respond.
Yeah, please go
madam,
ahead with your question.
madam, with my question, with my WBC stuff, so do you have to give the patient a broad spectrum antibiotic or what? Since the WBC
And what antibiotic crowd?
So the first thing you have to do is to determine from your history and physical examination where the infection is. And then you tailor your treatment to the infection. But it's very important for you to take a sample for blood culture and urine culture, so that you should take those samples before you start the history and physical examination tells you that it's likely to be an infection. Then you give broad spectrum antibiotics because you can't figure out what infection it is or where it is. So I'm presupposing that you've done a very good examination and you couldn't find anything. In that case, you give a broad spectrum antibiotic.
Okay, thank you.
All right.
So come and disturb mommy.
Yeah, making her laugh over there, so she's fine. It's when they make her cry that she come running to me.
Boys make her cry.
Yes.
Please, my question is about the WBC. I nursed the patient, sickle cell patient, and then the WBC was very high. We put him on antibiotic, and then instead of it coming down, he wasn't getting better. And then later he was diagnosed of leukemia. Within a month, he died. And I got a little confused.
Okay.
So he was fine.
Okay, so that's a very good question. That should tell you that when you have high WBC, the most important thing for you to do is to make sure from your history and examination what could be wrong with the patient. Let me explain something peculiarly about sickle cell patients. So sickle cell patients have a chronic ongoing hemolysis. So what happens is that the red blood cells are constantly being broken down because of the sickling, the sickle shape. When there's deoxygenation, the red blood cells would sickle and they would also undergo hemolysis. So whenever there is hemolysis, the bone marrow realizes that there's shortage of blood. And so the bone marrow needs to produce a lot of red blood cell precursors. if you look at the red blood cell precursors, they are larger than the normal red blood cells. And so when you are doing the full blood count, the automator or the machine that counts them as WBCs. You understand? So the large WBCs, they are called reticulocytes because of the increased numbers of reticulocytes in sickle cell patients. The WBCs are also high, but it doesn't always mean that they have an infection. Okay. In sickle cell patients too, other things can cause their white cells to go up. So leukemia is one of them. Okay, so what you do is that you also need to do a film comment. When you do a film comment and there are leukemic cells, they'll comment on it, and that will help you to direct their therapy. But sickle cell with leukemia has a very bad prognosis, so it's not surprising that the patient died.
All right, doctor,
Esther,
thank
are
you.
you okay?
Yes, doctor, I'm okay.
All
He
right.
was my friend, so.
Oh, sorry about that.
Madam, with the leukemia, is it also an immune deficiency or it's a disease on its own, pertaining the circumstances it's in?
Pardon?
Is it, you were saying something, madam, you continue.
So leukemia is a disease of the bone marrow.
Okay.
It's a cancer of the WBCs.
Okay.
So the bone marrow produces excessive amounts of white blood cells, which are useless. They are not able to fight off infection. Yeah. So in leukemia, when you take a sample of the blood, you realize that the WBCs are very, very high. It's one of the things that you can diagnose from a full blood count.
Okay.
All right.
Thank you.
Okay.
Hello, madam.
Yes.
If you have a sickle cell patient who always have pruritus, is it advisable to be given injection hydrocortisone?
No, so you need to understand that the cause of the pruritus is the excessive bilirubin that is produced. So it means that for bilirubin to be produced, it means the red blood cells are breaking down excessively. So once you address that cause of the increased breakdown, that's inadequate water intake. So once you tackle the underlying cause, it should be okay. We have 6 minutes.
Madam, how do you tackle the excessive breakdown of the blood cell? How do you tackle it?
So we have to talk about sickle cell. You ask any question about what we discussed. So
okay, madam, with my second question too is regarding you were talking about an infant having constant balls.
Yes.
That could also determine immune deficiency. I'm asking if an adult also has the same thing, is it likely to be the same, or maybe it could be a cause?
Yes, it could be an immunodeficiency condition, or there could be an underlying cause. Commonly, what we find is diabetes.
Okay.
So if somebody comes with recurrent balls, you need to at least check their sugar level. Okay, so your question about how to prevent the breakdown of the red blood cells. The hemolysis that usually occurs in the deoxygenated state and in the stress state. So fluid therapy helps to decrease the sickling.
Okay.
So just by taking enough fluids, and for an adult, you need to take at least 3 liters of water in a day. And so for a sickle cell patient, they need more than the normal for adults. So they need 1.5 times what you and I who don't have sickle cell should take.
Okay. Thank you.
All right. So for sickle cell patients as well, things like malaria can trigger the breakdown of the red blood cells. Things like infection can also trigger the breakdown of the red blood cells. So you need to assess the patient holistically and decide what are the problems. Once you tackle them, it decreases the amount of breakdown of the red blood cells, which will further decrease the bilirubin, which will further decrease the pruritus or the itching.
Okay.
All right. Any other questions? Are we all okay? This is our last lecture.
Oh, madam, you have to be. We will call you every evening and we have chat. We like it that way. Okay.
Please, I have things that I do.
We do revision, madam. Let's do revision. So
No,
next week
I'm
we do
thinking,
revision.
I'm thinking that I need to give. I'm thinking I'll give you a slot to the level 200.
In the evenings.
Hey, you are level 200, right? So I'll give you a slot. I'll give you a slot to the level 300.
Oh, madam, this one.
Yes,
Yeah.
they're also my children, so I need to take care of them. But well, I mean, we can discuss anytime you want any clarification. Why not? I'm available.
Madam.
Yes.
So are we done with pathology?
Yes, please. Pathology 1.
Okay. So when are we starting the 2?
Okay, don't you exams?
Don't you? Exactly. Don't you want to finish the exam? Yeah, so finish the exam.
So we are not meeting again. Madam, we are not meeting to the examination.
No.
You can come and meet, don't worry.
So this is our last lecture. So what we do is that I'll decide on the assessment and then I can put it on Google Classroom. Then we can meet to just discuss the questions, the answers.
Okay. Madam, I can help you put the questions and the answers in there.
Yeah, why? Mami,
I want you to finish. So what I have decided is that I want us to finish the exams for Pathology 1. Then we can start Pathology 2. So for Pathology 2, what we'll do is that we can, even when school reopens, we can have a Zoom session. And we could be done in maybe 2 weeks or 3 weeks, just by having Zoom sessions every evening. Then we'll be done with Pathology 2, yes. So even when the semester is ongoing, we will still do it. And then we can schedule a time and write the exams.
Thank you. You are the best.
Okay.
Thank you. I have a meeting at Medical and Dental Council in 2 weeks' time, whereby we are trying to restructure your curriculum. So if there's any change in the curriculum, I'll input it in the pathology.
Thank you. Thank you.
Madam, I hear what you said.
I said that I'll be attending a meeting at Medical and Dental Council in about 2 weeks' time towards your training, specifically training of physician assistants. We want to make a few modifications to the curriculum. So if we do and it affects pathology, I'll input it in the next batch of lectures.
Okay.
Okay. Madam, the way boy. Do two.
Okay, so it's been very wonderful teaching you. I'm very grateful.
Nick, why? You want to scare Madam?
Why?
And everything. So,
Madam, is Nick not scaring you?
We have less than 1 minute to go, so I just want to say
don't mind them. Oh, thank you very much.
Thank you very much.
Madam, we will miss you, but we will be calling you every evening 7 o'clock to come and do this thing.
5 minutes, only 5 minutes.
5 minutes, only 5 minutes.
5 minutes of Zoom.
Yes. 7 p.m.
7 p.m. to 7
for your time. We are very grateful.
We are very grateful.
We love you, mommy.
Oh, thank you.
Nick,